Question: a 1-day-old boy is brought to the ED because he has started looking blue. He was born full term at home yesterday and there was minimal prenatal care. Vital signs showed a temperature of 36.9 degrees Celsius, heart rate was 55, blood pressure was 55 by 30, respiratory rates were 66 breaths per minute, oxygen saturation is at 68% on room air. Physical exam revealed central cyanosis. There is a single second heart sound, no murmurs, and normal peripheral pulses. X-ray showed a normal cardiac silhouette with decreased pulmonary vascular markings. ECG shows a left superior QRS axis, tall P waves, and reduced right ventricular forces and left ventricular hypertrophy. What of the following would be our diagnosis? Would it be tricuspid valve atresia, persistent pulmonary hypertension of the newborn, dextrotransposition of the great arteries, or total anomalous pulmonary venous congestion? And the last option is tetralogy of Fallot. So let's begin eliminating from the last option, tetralogy of Fallot. What does happen in that condition? We usually see a boat-shaped heart on the chest X-ray. Here we know that the cardiac silhouette is normal. Um, Also, there is right ventricular hypertrophy and right ventricular outflow tract obstruction, which is seen in tetralogy of Fallot. But the ECG here is showing a left superior QRS axis. So that means that there is leftward deviation. So the left ventricle is where there is like increase in size or hypertrophy, and there are tall P waves which also denote like atrial dilation. So in tetralogy of Fallot, we would see right ventricular hypertrophy. So you would see a right superior QRS axis rather than a left superior QRS axis. Total anomalous pulmonary venous congestion connection. So in that case, when we have TAPV, the pulmonary vasculature increases and the amount of blood going to the pulmonary circulation increases. So we wouldn't see decreased pulmonary vascular markings. Dextrotransposition of the great arteries, again, there would be increase in the amount of blood that would be going to the pulmonary vascular marking. So that would be a ruling out factor. Persistent pulmonary hypertension of the newborn will present with decreased pulmonary vascular marking. So that is correct. But there won't be a single second heart sound. So you would hear an enhanced second heart sound, but you will not hear a single second heart sound. And even in persistent pulmonary hypertension of the newborn, you would see that the cyanosis or difficulty breathing would start within the first 24 hours of being born. So the fact that it took about a day for this child to start developing that cyanosis is not making me yet fully convinced that this is persistent pulmonary hypertension. Coming to tricuspid valve atresia. So if there is tricuspid valve atresia, in that case you wouldn't expect a good prominent S1 sound and you could have a single second heart sound. Also, um, in that situation you would also expect less pulmonary vascular markings because the blood flow to the pulmonary circulation would decrease. The ECG would show a left superior QRS axis. So when there is tricuspid valve atresia, you would expect hypoplasia of the right ventricle, which would lead to ECG, which shows left superior QRS axis, because if there is hypoplasia of a particular ventricle, the ECG sort of deviates towards the ventricle that is bigger in comparison. So hence the left ventricle would be obviously greater in size, and tall P waves would be due to the right atrial enlargement, which would happen due to regurgitation of blood since there is no tricuspid valve. And that would also explain the reduced right ventricle forces. So out of elimination, our best option here would be tricuspid valve atresia.